All right. We will call this Health and Human Services Committee meeting to order. I'm not Chair Cooper, but filling in for a little bit until she arrives. And we are going to start with House Bill 1069 by Representative Williamson. Bruce, you good to go first? If you absolutely. If you'll go ahead and present your bill as you're ready.
Thank you, Mr. Chairman, the members of the committee. I'm here today for a subsequent hearing for House Bill 1069 by committee substitute. I believe the committee members have received this substitute. It's LC 339088S. To refresh the members of the committees about what we talked about last time is this measure is seeking a new licensure category for adult mental health psychiatric residential treatment facilities. It's a quirk in the code right now that anybody providing these adult residential psychiatric treatment facility services has to be licensed as a personal care home. And the way the personal care home language reads, you can't control the visitors, you can't control the food they eat, you can't administer medicines, and you cannot, I'm missing one point. Control the foods, the visitors. I thought I said food, visitors, medicine, and packages. So you can't control if somebody has an obsessive compulsive disorder and they're ordering stuff on from Amazon all the time. It's probably a good idea to intervene in something like that. None of which you can do to someone that's in a personal care home. So there was a screaming need for a new licensor. We brought all the interested parties together, and with the help of Mr. Stan Jones, who is an attorney working very closely with the Department of Community Health, and we crafted legislation that narrowly defines what these folks do. It doesn't get involved in the CON issues, and it really will give the appropriate licensing for these facilities that are trying to meet the needs of our citizens of Georgia that have these disorders. I'd be happy to answer any questions the members might have of me, or I can present, let Mr. Jones go through any technical changes that we addressed since the committee last heard this bill presentation.
Sure. Well, we'll first see, does any committee member have any questions for Representative Williamson? Seeing none, Stan, did you want to add anything?
I'll just say that we made sure that this was tightened up to apply to a step down category of residential care. It's not acute care. It's the hospitals provide, both the psych hospitals and the general hospitals with psychiatric units. It's got a delayed effective dates. There's a time for DCH to implement the regulations. And we've worked hard to try to accommodate the different people who already operate facilities, like the community service boards operate the crisis stabilization units. So happy to answer any questions. That has been a long and winding road.
Do any committee members have questions for the presenter? Seeing none, there are a few folks who signed up to speak to the bill. Is Beth Finnerty?
Yes.
We're all
all here. Okay, great. Any additional questions from any committee members? What is the will of the committee? There's a motion. Is there a second? Second. All in favor of passage of House Bill 1069 by committee substitute LC 339088S, please signify by saying aye. Aye. Any opposed? No, by stating no. Hearing none, your bill's on to rules.
Thank you, Mr. Chairman, members of the committee. I greatly appreciate your support of this important legislation that will help Georgians. Thank you.
Thank you. We're going to take a brief recess. Well, We may be coming right back. All right, we're back. That was quick. So we will move on to Chairman Taylor's bill, House Bill 1449.
Thank you, Mr. Chairman, members of the committee. Today, I bring you House Bill 1449. This has to do with improving Georgia's children and family dental health. For a little bit of background, Georgia Families is a program that delivers healthcare services to members of the Medicaid and Peach Care for Kids. This is a partnership between the Department of Community Health and 3 private care management organizations. The state uses this model to improve the delivery and quality of healthcare services for Georgia's children and families. The goal is also to improve the accountability to taxpayers while maintaining a predictable and a sustainable growth for DCH. Dental services are just one of over 20 services administered by the plan by the state. The problem we've had, and it's been down this road before, is being able to see if that famous transparency is there. Are we able to see how well the programs are working? Because so many services are administered by CMOs under the Georgia Families, and many Georgia healthcare kids and families are not aware of these preventive dental services that are available to them. Because dental is one of many competing priorities, there is currently no way for us to know, and there's a low likelihood that these medical plans are investing what they need to for the dental innovation and services that our children need. The General Assembly cannot currently assess this model because the CMOs have not disclosed on the individual basis how these funds and what the services are. I do this for a living, and one of the things I look at is how the dollars are being spent, what type of services are being offered to our members or patients. And with this, we're not actually able to see. I think it's important for us to do. This is why the Georgia Dental Association and many Georgia dental providers are seeking greater information so we can tell what's happening. If we can't see, we can't know. One way for the General Assembly to achieve more clearly is how Georgia's kids and families are receiving their services is to carve out the dental administration and require the use of what are dental organizations like CMOs. There are 18 states that have already chosen this model as a means for greater transparency, but also for better program outcomes. And that's what we're looking for. And an overall health improvement is there when dental services are being provided. Costs that can be tracked and analyzed by the appropriators, which is us. We are the appropriators, but we can't currently see how they're being done. I think it's up to us to see that it is done. And I'll be happy to answer any questions.
Do any committee members have any questions for the presenter? Number 3.
Thank you. I just wanted to say that the fact that CMOs do not have to give out their financial information is a problem. And that is what I was talking about with mental health, where I can't find the numbers. It's the same thing. How are these entities getting so much money and they don't have to report it? I don't get that, but that's just, I feel you when you said that.
Chairman Cooper.
Thank you, Mr. Chairman. Is it my understanding that just before and today that you have come to agreement that we won't take a vote on this, but that a study will be
If the
done?
lady would choose to do that, we are open to being able to discuss it, to find out if there's a better way to approach it. So I do want to make sure that there is information out there for us to make good decisions and for our patients to get the best care. So I am open to whatever is your discretion.
Well, I know the lady is one to look at the details and try to find the best approach. So I think if there are no other questions, or if there is somebody from the audience there, you can move on to that, but afterwards we will just hold the bill and let you go forward. And I understand that would be a study committee.
I'll
Or a
have to
study.
see- Yeah, a study done maybe through your committee. I don't know that they're going to do any more study committees for the whole house. Does that
Will
make sense?
will you check and find out in case we have another meeting on Thursday, in case we need to hurry through something so
Okay.
that we make sure that this gets done?
Thank you. I will.
Okay,
Thank you.
back to you.
We do have a couple additional questions from committee members.
Oh, yes, sir.
Representative Mathiak.
Thank you, sir. Is this proprietary information again? Are we up against that?
No, it
piece.
wouldn't be. When you're looking at the type of services, you don't have to get individual numbers as far as Mary Smith got this service, but you could look in general, all the 6-year-olds got their
Right.
preventive care or those type of things. And are they getting preventive, or those that have waited? Then you have to get treatment for caries and things like that. There's a lot of different aspects of following it. It also is age factors, male, female, a lot of things like that. I think we just don't know. And are they investing back in the preventive? I also want to see what they are investing in PR to make sure people are aware of these services are even available.
Thank you very much.
Thank you.
Representative Hawkins.
This is just a comment, Representative Hutchinson and others. We passed HB 1276, which is transparency bill. A lot of these per member per month figures are going to be printed on the DCH website in plain view. So we're going to be able to see some of this stuff we've never seen before. It was mired in contracts, which understandably, I mean, for years, a lot of us went after the contracts, but that's a problem, you know, when we're reading the contract information and how they're bidding against each other, and that is their private information, and we understand that, but it's the state's money, and we're going to be able to see that. So it'll be helpful to all of us, make good decisions.
Chairman Cooper.
Okay, wait a minute. Betsy, I have a question. Oh, it's not Betsy. Okay, to our legal counsel that we have. I was going to make a motion to lay this on the table, but what happens if the chair lady needs to use this bill, to strip this bill out and put a study committee on it? Well, we would take it off the table. We just take it off the table. I
Okay.
answer my own question. Thank you. We just don't usually do that. I'm recognized. Okay, I would like to make a motion that we put House Bill 1449, lay it on the table for now.
We have a motion, a second, to lay House Bill 1449 on the table, and a second. All those in favor of the motion, please signify by saying aye. All those opposed? Hearing none, it is on the
Thank
table.
you.
Okay. so
Thank
we
you.
have it as-
I will get back with you
Strike it.
ASAP.
I mean, strip it out if you need to make it a study committee one.
Thank you.
You're welcome.
We will now move to a hearing on House Bill, hearing on implementation of House Bill 888 by Chairman Hawkins.
Thank you. I'm just going to do it from here because we have a number of people to speak. You remember 2 years ago, we did the surprise billing, the first one, 888. This bill spoke to the issue that we'd seen for some time. And a lot of that issue came about with patients going to an in-network hospital, but being seen by an out-of-network physician. You know, we do live in a country, luckily, that is a free country. We get to make decisions. That includes the decisions made by the people that treat us. And the problem came up, though, that we had the providers deadlocked or in the headlock with the insurers over their compensation for their treatment. Often, many times, insurers were actually reducing the cost of their treatment, and that had been going on especially since 2017. And we had that in the bill that they would pay them at least what they paid them in 2017. But to make up for the physicians agreeing to this part of the bill, we put in there the arbitration process. That was valuable for a couple of reasons. One, it helped protect them. And also it helped get the information and the evidence out in front of everyone about what was going on with insurance claims, whether they were being denied or whatever. We've had some issues with the performance of the arbitration process. This takes a lot of time. I can tell you the DOI has worked diligently on this, but this also goes to arbitrators. So you're going to hear from some of the providers and some of the problems that they're encountering. Thank you.
Thank you, Chairman Hawkins. We do have a few folks who are signed up to discuss what you just mentioned. We'll first start with Greg Conley with the Department of Insurance. If you want to come up to the podium. Introduce yourself.
Yeah, thank you, Mr. Chair, committee members, Representative Hawkins. My name is Greg Conley. I'm the Executive Counsel at the Department of Insurance. And I have been heavily involved in implementing House Bill 888. It has been a big lift, but I think it's been generally beneficial to the state and to consumers. We've received approximately 3,000 arbitration requests since the program went live. That deals with approximately 20,000 patients. About a third of the requests we receive require some type of additional investigation. They're not received in complete form. We've had about 7% of those, about I think 250 of them have settled. And I think we have another 1,000 that are in settlement, and the rest have been moved to arbitration. So far, themes we've kind of seen. I think that arbiters have found for insurers 52% of the time. So I'm sorry to all the doctors here, but that's how the arbiters have found. The main delays we've seen, we had some inner delays on our part. The initial influx of claims was very high and very hard for us to work through. We're currently working as fast as we can to get through what backlog we have left. The rest has just been sort of the learning experience. I think for providers and insurers alike, it's a new process, kind of learning how to submit arbitration requests in an efficient manner and get those done. But we're so far happy with how it's gone. We think we're getting better day by day. And I would welcome any questions from the committee concerning the program.
Do any committee members have questions for Mr. Conley? Seeing none, we will go on to Zoom. Dr. Downey is on Zoom to provide some additional information on implementation of House Bill 888.
Great, thank you very much. I'm Dr. Rebecca Downey. I'm the Vice President of American Anesthesiology Associates of Georgia. This is a practice that has patients living in rural areas in Macon and Savannah. I'm a graduate of the Medical College of Georgia at Augusta University and a board certified anesthesiologist. I'd like to thank the committee as well as Chairman Lee Hawkins and Madam Chair Sharon Cooper for the opportunity to offer a few comments on the implementation of HB 888. And we're grateful that Georgia has worked to take patients out of the middle with the passing and enforcement of this bill. The surprise billing law that you helped pass 2 years ago has started to move the needle in Georgia in a meaningful way. And since then, Commissioner John King and his team have taken their enforcement responsibilities seriously when it comes to protecting patients. But we still know that there are bad actors who are not following the law appropriately. For American Anesthesiology Associates of Georgia, the majority of issues are with United Healthcare. When insurance companies toss aside fairly negotiated contracts with providers like us, our next lever is now the surprise billing portal. For the patients, though, this particular status of getting thrown out of networks forces those patients and their families to move away from trusted medical teams, finding a different facility, or having to face higher bills for health insurance claims that were previously covered by insurance. Insurers like United Healthcare try to game the system and take advantage of smaller healthcare systems. So while the surprise billing arbitration process is a very welcome tool, it's labor intensive, especially for smaller providers that don't have large billing and administrative staff. Insurance companies have found ways to obfuscate and kick claims back to us that we know they should be paying. Large insurers are hopeful to tie up payments they owe to these providers by forcing us through unnecessary arbitration processes. For example, the surprise billing law indicates that if a provider becomes out of network, the payment should revert back to the last contracted rate if the contracted rate is higher than the overall median rate. For the out-of-network claims, certain insurers are well aware that the prior contracted rate is the required allowed amount, but instead compensate far below even the median contracted rate. Other examples of gamesmanship include untimely payment, incorrectly reporting claim status on the OCI portal, and refusing provider requests for efficiency by collectively settling claims in the OCI portal. Some insurers are banking on creating a backlog since they know they can sit on these claims and have time to spare. We don't. The surprise billing law is a great lever, but we know some parties are not adhering to the law in good faith. I can only speak for myself, but it's our overwhelming desire to be in network. We'd rather have contracts with fair rates so that hospitals can reassure patients that they won't be balance billed and that their network status is secure. Insurers would prefer to sit on outstanding claims when cash flow is critical to sustaining healthcare providers and recruiting and retaining the very necessary talent to provide those services. Insurance companies appear to be indifferent to the impact that this has both on providers and healthcare systems alike. So it's critical that lawmakers such as yourselves keep a watchful eye on marketplace conduct and determine if there are any other legislative fixes that will continue to level the playing field when it comes to protecting providers from some of the sharp negotiation tactics that insurance companies like United Healthcare use. Tactics that we believe jeopardize access to care and services to Georgians across the state, but especially in rural areas. So I want to thank you for the time today, and I'm happy to be a resource for the provider experience. If you need commentary or information, I'm happy to answer any questions that you might have. Thank you.
Thank you, Dr. Downey. We do have two additional individuals sign up to speak on this measure here in the room. Dr. Pettigrew, who is from my neck of the woods over in Watkinsville, and Dr. Smith, if y'all want to come up to the podium and share with us as well. Either way, it's fine. Thank you.
That's fine. Chairman, members of the committee, my name is Jay Smith. I'm the current president of the Georgia College of Emergency Physicians. First, I'd like to say thanks for taking the time to hear this. I know y'all have had a very hectic session. I'd also like to thank the Department of Insurance, as they have made themselves very available, and we're appreciative of the efforts they've done thus far. To my right is Dr. Pettigrew. He's a past president of the Georgia College of Emergency Physicians, and he's also who I would refer to as the tip of the spear on this information, as I really don't know anyone who's not more educated or up to date on it. So with that, I will defer the remainder of our time for him.
Thank you. As mentioned by Dr. Smith, I'm Dr. Pettigrew. I'm a career emergency physician. After my military obligation, I moved to Athens, Georgia, and spent my entire career practicing emergency medicine there at Athens Regional. I'm here on behalf of the Georgia College of Emergency Physicians to communicate and comment on the implementation of HB 888 and several issues that come up from the provider's perspective. I'm very familiar with these issues as a board member of the Georgia College of Emergency Physicians and as a active chapter member and committee member and leader of multiple other organizations that follow and track these types of revenue cycle management problems in emergency medicine. First, like to address, and I think you have a handout that was provided to you, insurance company and payer issues. Insurers are, for the most part, not identifying Erisa plans versus state-regulated plans in a clear and consistent manner, if at all. This is a violation of HB 888, and I put the specific paragraph and subparagraph reference in my comments. Providers are having to contact insurers on many of these claims to see whether or not they are state-regulated, or ERISA, which you know the state-regulated falls under HB 888, and now the federally regulated would fall under the NSA in the state of Georgia. Physician offices are not staffed to do this volume of work when insurers should be complying with the clear law and identifying what their plans are. Secondly, some insurers are sending out-of-network payments to patients instead of physicians, forcing physicians to be in the awkward position of having a don't balance bill the patient's law, but now having to bill the patient because they've been paid instead of the providers. This also is a clear violation of HB 888, 20E, subparagraphs 4B. Insurers are not making their payments in accordance with the formula that's provided in HB 888 for out-of-network emergency services. This is a clear violation, and I've again cited the direct passage for that. Most physicians that I've talked to and their management back offices feel that appeals would be not necessary if insurers were simply paying in accordance with the law. And that's the way the law was written. When insurers violate the law and they do not pay in accordance with HB 888, this forces physicians to bear the burden of filing appeals, tracking appeals, and having delayed account receivables. Some insurers are underpaying claims and then waiting to see if there is an appeal. Only when there's an appeal which is filed do they pay in accordance with the formula of the law. Others still don't. Yesterday, I was informed that some insurers are refusing to pay the DOI in accordance with the database that was designated, pay the providers in accordance with the database that was designated by DOI because they say it's was never officially established as a database, did not officially come out in regulations, and they're not going to pay for it. And so therefore, instead of having the greater of 3, we've got the greater of 2 now, which is not the intent of the law. And so that's been very frustrating for us also. Also, insurers are not acknowledging efforts by providers to negotiate during a 30-day negotiation period. This leads to confusion on behalf of the providers as to whether or not the insurers are even in receipt of the copies of the provider's notice of an appeal. The insurers seem to be using this tactic to delay the appeals process, further disadvantaging physicians, their office staff, and their AR. Secondly, Department of Insurance implementation. We appreciate the massive task that they had with implementing this law, and we know that there's a ways to go. We don't believe that they were specifically funded to put all of these processes and regulation into effect and manage some of the things that they're required to manage. We're working with them on a direct basis. Greg Connolly and I have agreed again today to meet again on some of the specific issues that we have, and we're moving forward with these issues. Thirdly, the IDR process. We do have some issues with the IDR process. First of all, it was tough in its implementation. And I think probably the insurers would agree with that also. Maximus, which is the IDR entity, they're sending out generic emails requesting copies of all kinds of insurance data, plan information, and the physicians don't have any idea what this is, and the physician offices are trying their best to compile this stuff and figure it out and call the insurance companies, and we're just not sure whether that's our responsibility or not, but we're doing that because we're afraid then if we don't do all that, then we would just have our appeals denied for improperly following procedures. But we don't think that was the intent of the law, to make the physicians' offices for providing all of the insurance information to the IDR. We also understand that Maximus would appreciate spreadsheets information coming in spreadsheet formats, but for now, that's not been authorized, and so that's kind of problematic because then most physician revenue cycle management companies and back offices, they put information on spreadsheets that they're tracking and following, and then have to then manually put this into another format. For Maximus is difficult, and you might make a mistake on a little number here or number there and have a bad appeal on that. But actually Maximus would rather us send them the spreadsheet. So we would like to have some assistance in nudging and getting that taken care of for us. I guess finally, the IDR process is extremely behind. They're 4 months behind as of information that I got last Friday. And the delay in the timelines, the HB 888, as you may recall, has specific timelines in there. So the providers, being hospitals and physicians, they wouldn't be burdened by lengthy appeals and having their AR lengthened out to an untenable amount of time, but that's actually what's happening because the guidelines for the timelines are not being followed. I do have a couple of recommendations. I think that DOI should mandate that insurers pay in accordance with the clear formula written in HB 888. And as I stated before, if that was happening, there would be very, very few appeals, at least in emergency medical services, which I understand are, for right now, one of the larger components of the IDR process. Number two, I think since insurers are not complying with the law, then DOI needs to threaten them with the unfair claim settlement practice actions, which is written into HB 888 and still unused. And I think it's maybe time to use that part of the law. Should those two recommendations not be implemented, then I think that the legislature is going to have to allocate significant more funds for Department of Insurance for more staffing and more technical people in order to upgrade their appeals forms and their website, which is rudimentary at best. Finally, our last recommendation would be that if network adequacy laws were either implemented or enforced, then none of this would be an issue. I stand ready for questions.
Do any committee members have questions for Dr. Pettigrew or any of the other presenters? Chairman Cooper?
I was sorry, I didn't mean to be rude. I was asking Representative Hawkins if we're very late in the session to make any kind of changes now. It's really sort of too late to introduce a bill. Sometimes if there's a bill in the right part of the law, we can strip it out and add it to it. But he said this was more complicated. But I think maybe Representative Hawkins and myself, we need to go talk to the insurance commissioner, if that would be. But I did want to say to the medical students and the residencies, this is why you need to belong to your association. You've got a good example here of why it's so important that we have input for physicians when they're out working. And because we don't know what's happening in your offices and how much trouble and how things are being denied if we don't hear from you. And then we need people to come and testify. Yes, does it mean that you take some time off from work to do it? But it's critically important. And if you don't take the time, at least if you belong to your association, you are helping support the people that do take the time and do come down here and talk to us. There's only one doctor in the house. Lee's a dentist. I'm a nurse. There's one other nurse. Out of 236 legislators, there's only about 10 between the two places, 11, that have any kind of patient care experience. So we look to you to bring it to us. So thank you to both of you for taking time to come and discuss this with us. Thank you.
Thank you. Chairman Hawkins?
Yeah, I just want to say for the record, I know both these gentlemen, I've worked with them in the past. They're upstanding physicians. They work very hard to represent their associations, and I appreciate what you do. We left the bill open on how what the fees would be based on. The insurance commissioner chose fair health. That's what it is to be in the regulations. This state has passed laws on prompt pay, on assignment of benefits back in the 90s. Those laws are still on the book. The problem with a lot of healthcare legislation we've passed is something called Erisa. If it is not a state health benefit plan or a religious plan, and if it is an employer plan, then Erisa blocks the state from implementation of state laws. We don't like it, but that's the way it is. So we're still working around that. We did pass a second piece that allows the employer to choose a plan with arbitration to get around the Erisa law. But I'm willing to continue to work with you on this issue. If you can give me some specific cases, case numbers and things like that. I mean, don't give me 1,000 of them, but give me your best ones. Then I'll meet with DOI for you and we'll see what we can do. Because you're right, the bill says pay on the 2017 fee or the most current contracted rate, the greater of the two. So a lot of issues you've brought up, but I can tell you I've been very pleased working with Greg Conley in Weston Burleson. So we'll keep working on it. Okay. Thanks.
Thank you, sir.
Thank you, Mr. Chairman. And he's seeing no other folks signed up to speak or comments from the committee. We will now move to House Bill 731. Chairman Jay Collins, if you want to come up to the table there and present your bill we have a hearing only on House Bill 731. If you also want to introduce your guest as well.
Yes, thank you. And thank you to the members of the committee. I know that you have a lot of things going on, and I don't want to pretend to be an expert on this surgical smoke issue. It was brought to my attention by a constituent, and I've been learning and educating myself, and I know this committee has a lot of important matters before it, and I just want to thank you for taking the time for a hearing today. I just wanted to let her introduce, Ms. Brenda introduce herself and tell you a little bit about her credentials and about the smoke bill legislation that we're asking for.
Hi, and I echo thanks for hearing us today, here representing the Georgia Council of Perioperative Nurses and the Georgia Association of Surgical Technologists. Those are the people that we are working to try to introduce and pass House Bill 731 to protect staff and patients from the harmful effects of surgical smoke. I only learned about this hearing late last night, so I wasn't able to send you packets, but everything I have to say to you is well documented. Surgical smoke is human parts that are flying around in the air that people who work in the operating room are exposed to every day during their shift, whether it's 8 hours, 10 hours, and there's an abundance of documentation, including more than 250 peer review articles that support our surgical smoke guideline. Our definition of surgical smoke is that it is captured before it reaches the nose and the eyes of the practitioners because of the things that it does to your body, in your body. Our bill, this is our third trip to the Capitol to try to get some help in our hospitals for the nurses and technicians. And over the period of time, our bill's been called an unfunded mandate. 82% of hospitals in Georgia, and we did this survey in 2020, already have the equipment in place to evacuate and filter surgical smoke so the team doesn't have to breathe it. 100% of the hospitals in Georgia already have suction, and oftentimes that's all they need. So the hospitals don't have to spend a lot of money on equipment. Many already have it. There are numerous research papers that document that nurses who work in the operating room are more than 2 times likely to experience respiratory problems than the general public. I started to work in the operating room at Emory in 1975. In 2012, many years after I started working, I was diagnosed with adult onset asthma. So it takes a long time for your body to actually experience the symptoms. And we have Angela Hahn with us today, who is also going to speak to you. I've heard accusations that we don't have any randomized clinical trials. We do have one randomized clinical trial from 2020 that documents the bad stuff, including formaldehyde that's in surgical smoke, and the fact that smoke evacuation helps clear the air before it reaches the nose and the eyes of the practitioners. Surgical smoke is supported by Joint Commission, OSHA, the CDC, a number of agencies who recommend it to hospitals. The implementation of it has been a random interpretation of what the different agencies' guidelines say, but it's on their website today that they support smoke evacuation. 6 states have already passed smoke evacuation legislation, and 12 states have bills in their specific houses at this time. In each and every case in every one of these states, it's been an organic grassroots members from nurses like Holly, who went to Representative Collins, who went to my representative in both the House and the Senate, and asked you to help protect us by implementing legislation that will make it a practice that surgical smoke is evacuated and filtered in every single case where it is produced to protect workers and other people. So we ask for your favorable consideration. We hope that you will also give us a vote at some point, and thank you very much.
I would like to say one other thing. It's kind of ironic we're here today at this time. I believe the Senate just voted to pass a measure similar to this today. One of the things that caught my attention about this when the information was sent to me, I'm a funeral director and I'm a licensed embalmer by trade. And, you know, when we start talking about formaldehyde, you know, I spend a lot of money at my business to make sure that the reduction of exposure to myself and staff from formaldehyde, a chemical that we readily use, we're regulated by OSHA. And so the exposure to formaldehyde was a very, very compelling argument to me as a professional. And that's why I took an interest because my constituent brought this to me. So, you know, I'm learning about this as much as anybody. And I know this committee is very deliberate in the process that they pass legislation in protecting the consumer. But I think it's time we look at some legislation that will protect those people that render health care to us each and every day.
Chairman Cooper.
Okay, I have questions because this bill's been, our bills like this have been floating around. And thank you, Ms. Brenda, for your testimony. And the doctors, I would ask our doctors that are representatives now would say that, you know, like one was a hand surgeon. Okay, was this a real problem? And they'd say no. And then I would ask other physicians as I go to all these meetings, and they would say no. And then, or they would say, we already have the equipment, which you just said, they've got the equipment and the suctions and stuff. And they said, we use it when it's necessary. So if they already, most of the hospitals already have this equipment and they tell me they're using it when they need to, what do we need to do differently? Why is this a problem?
Now, people, surgeons or whoever is using the actual electrosurgery device can decide whether or not they want to use it or not use it. And it's our position that anytime that you are breathing the chemicals in smoke, toluene, benzene, formaldehyde, HIV, the SARS-CoV-2 virus has been speculated that it is also contained in surgical smoke. Anesthesia departments started using smoke evacuators once the COVID virus came out, just because of the likelihood of contaminating somebody with that virus. But as long as it's arbitrary, this place will use it, this place will not use it. Surgical smoke is always a danger. It's like, cigarette smoke. If you smoke one cigarette, are you going to get lung cancer? Probably not. But over a period of time, it's cumulative. The other point that I think is important is that nurses and technicians are in the operating room 7 days a week, 8, 10, 12 hours a day, depending on what their shift is. So their exposure is much greater than anyone else's except anesthesiologists who are also there and anesthetists. So it's the level of exposure with the nurses and technicians is so much greater than the episodic exposure of surgeons and other people who are in and out of the operating room.
So the problem that you see it is the fact that it's still optional for the surgeon to whether they use it or not.
It is optional, except when hospitals make the decision that they are going to go smoke-free, and that every time a procedure is done that produces smoke, that it is evacuated. There are hospitals that are in the process of doing that now, but it's still, we see the outlying smaller hospitals as being the ones who need the most help, because nurses and technicians are employees of hospitals. They're not bringing in revenue. They're a revenue drain on the hospital. And so when their needs are being considered, they're lower on the totem pole than anybody else is, the ones who actually bring in the revenue. So it's an uneven balance of power.
Well, I knew that there was a reason I didn't like, being in the OR, besides the fact that I got a pair of scissors thrown past my head when I was a student nurse. So, there are good reasons to stay out of there.
And that's another issue that I had.
About the scissors.
No one bringing forward this legislation. You're talking about smoke-free zones. The OR is really the only place that the hospitals aren't regulating smoke. I mean, on the campus, you can't go to a hospital in Georgia. I don't know of any single hospital in Georgia you can go to and smoke. That's been completely done away with, and rightfully so.
Representative Schofield.
Right. Thank you, Mr. Chair. And I wanted to thank you, Representative Collins. I know we had some talk about this. Mike spent a lot of time talking with my cousin, who's the chief anesthesiologist at Wake Med, and this was a problem. So I really thank you for this bill, because for the amount of time that he spends in the OR, this is actually saving his life. He's 35 years old. And we want to see him live a long life, not just because of the love of his profession and saving lives, but we want to protect you and everyone else. So thank you for carrying this bill.
Representative Hutchinson.
Thank you, Mr. Chair. I just had a quick question. Did you say that nurses inhale HIV?
There's documented, published, peer-reviewed literature where the particles that are released whenever the electrosurgery units are used contain HIV, and that's in the literature, and it's accepted that the exposure to that is possible.
Okay.
Chairman Cooper.
Well, this certainly says something about the state and the effectiveness of the surgical mask you're wearing in the OR. I mean, and if the surgical mask in the OR don't work, I think that certainly lends credence to all of us that have, not all of us, I've worn the mask, but many of us that have fussed about the fact that we had to wear the mask and they were absolutely useless. I mean, so are you not wearing a higher quality mask, surely, that, that blocks some of this?
There are 3 different kinds of masks. The one which will block more of the particles that are coming up in surgical smoke is the N95. It will block 95% of some of those particles that are in the surgical smoke. The problem with that is it does not block any of the gases. The toluene, benzene, formaldehyde is not blocked by an N95. And the N95, you can't do a job in the operating room wearing an N95 all day long. I'm sure during COVID, you saw some of the pictures of the faces of the people that had to wear N95 masks all day long. It's very, very difficult to do. Working in the operating room is very physical, and it's not just sitting down breathing, it's trying to move around and take care of patients. So they are not ever, and this is it from CDC and from Joint Commission and OSHA, a mask is never supposed to be considered the first line of defense against anything.
Seeing no additional questions from committee members, we do have 2 other folks signed up to speak to this measure. Angela Horn, would you like to come up to the podium? Please introduce yourself.
My name is Angela Horn. I'm a registered nurse. I thank you for the opportunity to be able to testify this afternoon. Back in 2020, I was diagnosed with stage 4 lung cancer, and I'm a perioperative nurse since 1979. My physicians and my oncologists attributed my disease to my working condition, and being an operating room nurse, I did wear my mask. I did do all the PPEs that I'm supposed to do. And yet I did contract lung cancer. I am not over it yet. I'm doing a whole lot better than I had been. But, I just feel that I need to speak up as an advocate for those who are coming after me, that that there be a bill, that this bill be passed, excuse me, and that there's be more concern and consistency about how staff, nurses, techs, anesthesiologists, anesthesia techs, patients, how they're treated with the risk of being exposed. When I got my lung cancer diagnosis, I have never been a smoker, and I have not had smoking in my home either. So the risk of me contracting lung cancer was minimal as far as I was concerned, yet I did. I did get this diagnosis and I'm still being treated. So my desire and my appeal is that a bill be passed, some kind, I don't know how you what the terminology is, but I'm just saying, you know, when I went to see one of my doctors earlier this year, they told me without any kind of bedside manner, you should be dead by now because I'm stage 4. So I'm saying all of this to say, I'm not looking for a pity party or anything like that. I want to be an advocate and I want you to hear me and know that I'm living, I'm breathing, but not without risk. So thank you.
Thank you so much for your testimony. We really appreciate it. We do have Dr. Sharma on Zoom is our last individual to testify on this measure.
I hope you all can hear me, and I apologize for not being there in person, but as you can see, I'm a little bit clinical today, so I hope you can hear me. I really appreciate this opportunity to present on this topic, and appreciate the opportunity from the committee members and the chair for this invitation. My name is Joe Sharma. I'm Vice Chair of Quality, Patient Safety, and Innovation in the Department of Surgery at Emory. I'm also on the Board of Governors for the American College of Surgeons, and currently serve as President-elect for the Georgia chapter of American College of Surgeons. Have been in the field of cancer and thyroid cancer in particular, which is my area of research. And that's where I've actually looked at environmental chemicals and thyroid cancer. Been doing that for about 17 years. And on my other hat is the Chief Quality Officer hat. So have worked around patient and provider safety for a long time. And I think that this issue is near and dear to my heart also, specifically since it is where I live. And additionally, as someone who's sometimes the closest to the patient and has the greatest proximity to exposure from surgical smoke, this issue isn't just a professional thing, but it's personal for me also. The question in front of us today is, do smoke evacuators protect the operating room personnel by reducing exposure? And that is, I think, a little bit of a different question than whether they have carcinogens or other potential toxins in them. The smoke has been touted as risk of cancer, infections, and other pulmonary diseases, and most of it is very poorly established in literature. So I'm not going to delve into the cancer development and exposure and contents of surgical smoke, which, by the way, 95% of it is water vapor. Let's talk a little bit about what I think is the crux of this. Does this smoke evacuator actually minimize the risk for nursing, anesthesia, and surgical personnel? As was said earlier, the technology around this has been around for more than 25 years since I trained. But there are two examples I think that would be useful to hear about. One of them is the human papilloma virus, which has been around for a while, and a lot of the operating room protection that we use, it comes around this virus. And there are 3 arms to this. This has been published most recently in the Occupational and Environmental Medicine Journal, where 21 articles were reviewed. And the 3 arms that they identified were local exhaust, which is kind of the smoke evacuator, general room ventilation, and full personnel PPE, especially the N95. They say that transmission of HPV in surgical smoke remains unproven. And from an abundance of precaution and safety, they recommend primary reliance on PPE, but also state that local exhaust and smoke evacuators may be effective, but they have not been proven effective for adequately reducing smoke. In the operating room, we rely mostly on PPE to prevent injury during surgery: gloves, double gloves, gowns, eye shields, and masks. And this is another example of a technology that may affect us, but it has not been proven. And again, the second example, I think, which has been very relevant to all of us and which was mentioned by my colleague earlier, is what do we do during COVID transmission? And again, there have been nurses, surgeons, and anesthesiologists who have been affected by COVID and have been infected by COVID. And unfortunately, I can say, I know of some who have lost their lives to COVID during this pandemic. And in that initial phase of the pandemic, we actually brought in smoke evacuators to prevent this transmission. However, as we evaluated it, it did not decrease the risk of transmission. We relied upon N95s and other types of PPE to prevent this transmission. Again, the PPE upgrade was what we fought for in the operating room, and I think it was effective. The last point I'd like to say is, there are procedures where smoke evacuators can be accommodated easily. There's no doubt. As somebody just said, it's already available. But there are procedures where the evacuation technology will actually hinder the completion of the procedure. There are many handheld devices that we use, electrosurgery, ultrasonography. There are things that we use that are laser based. And the addition of the weight of this smoke evacuator can be a significant burden to completing the operation. Again, not in all procedures, but in some procedures. And again, that was the last thing I was supposed to say. But there is a difference between visible smoke and the plume. The details here are important. There's one other area that I think we should realize, that besides not being effective, the data around this and what is being pushing this is industry sponsored and industry reported. It is not in high quality peer reviewed journals. It is not part of high recommendations of what technology to use to reduce this exposure. So I think we have to be really careful before making broad statements that this will actually reduce surgical smoke. I think we have to be cautious in this mandate. I do think that there is room for study here. I do think that health technology assessments, which have been done by numerous health agencies for other things, should be performed here before we accept the mandate. And I'm happy to take any questions that are from the committee members.
Chairman Cooper.
So basically, and Doctor, you were saying we really shouldn't at this point pass a mandate.
Yes, ma'am.
Okay, that there should be more studies done. Is Emory willing to participate or maybe instigate a study?
I think I would be happy to take that on. I would look for some funding for that, but I'm absolutely happy to do that. This is my area of work. We've subscribed numerous grants looking at provider and patient safety during the pandemic also. So happy to be a lead on that and partner with a lot of the people that were here today.
Thank you very much for, addressing us. Is that okay? Go ahead and ask and I'll come back.
Representative Sharper.
Thank you, Chairman. I'm just interested in knowing, on the financial end of this, who are some of the, I guess, manufacturers or people that would be supplying this equipment? Where are they involved here? Where are they in the room? I mean, because I would like to know more really technically about the machines themselves as well. And, if we're going to mandate something and we require them to have the different machines, things like that, how long will they last? Or is there a particular one that we need to use with the system as a whole? Those are the things that, if we're going to mandate, if it's going to last a short time, and then next thing say, okay, we got to come up with a different system itself and the financial burden that it would put on others. But just overall, I just want to know, let me know about this manufacturers.
I have had no conversations at all with any manufacturers or any sales men or women of any manufacturing company. So I can't speak to that. Maybe Ms. Brenda can here.
We don't recommend any particular kind of smoke evacuation equipment or supplies. That's left totally up to the hospital. I did do a cost analysis when we had our first study committee in 2020, and I costed out the different kinds of smoke evacuation that can be instituted. And I don't know if you caught my comment in my opening comments that 100% of the hospitals in Georgia already have smoke evacuation. You can't do surgery with, suction. You can't do surgery without suction because it always produces blood. And frequently, the only thing that will need to be used are a Yankauer suction tip hooked up with an inline filter, which costs $8 per operating room per week. They don't change them every day. So hospitals, I would bet that greater than 30%, including hand surgeons, wouldn't need to use anything other than a Yankauer suction tip hooked up to the already present suction system with an $8 smoke evacuate inline filter that lasts a week. As surgeons select, and surgeons do select the handpiece that they want to use and the other pieces of equipment, it will be the hospital staff who would select the smoke evacuators. If they decide that using a dedicated unit, and most of them are not very big, whenever they range in price from about $1,000 up to maybe $5,000 if they want to go to the Cadillac version, and would also depend on hospital buying contracts. Those are probably amortized over about 5 years. And the cost of that is like 85 cents per operating room per day when they're amortized over a 5-year period. So the cost is minimal. The more hand pieces that are added on because of surgeon preference, the cost increases just a little bit. The electrosurgery pencil is already there. It's used on every procedure. There's a little a thing that it can attach to the bottom of the smoke evacuation pencil to evacuate that. There are other things that can be used. 100% of cases that are laparoscopic today, and that is the biggest majority of cases in the operating room any longer are laparoscopic cases, they always use smoke evacuation for a number of reasons. And there are certain cases that are always designated as being cases that use smoke evacuators. The human HPV is one of those where surgeons will almost always use smoke evacuation with that. It is our position that there's enough in the smoke all the time for it to be routinely used. It's a practice change, I know, but it's one that positively affects the air in the operating room.
Okay, and so mainly through the process of cauterization, that this will be something that's really close in versus a bigger suction system, but right there cauterization, and it's catching the air and the smoke and everything kind of immediately.
Yes, in the
Okay.
literature, it's documented by one of the agencies, and there are many, many peer review study. I have one from Lakota out of Japan, where they did a level 1, category 1 randomized clinical trial on whether or not, and I have that study with me, on whether or not smoke evacuators work, and they do. You might also be interested in knowing that in all the time that we talked about cigarette smoke, there was never one single level 1 study with linking cigarette smoking with causes disease in humans. So this is worse than cigarette smoke because it's living human tissue that goes up into the air, as Dr. Sharma says, carried by the water vapor. It's the water vapor that is the carrier for all of these things that get up into the mask when it's breathed. So yes, the recommendation is that it's either a handheld piece. If you want to get a little further away, you use a piece of tubing that can be a little bit further away. There are lots of different ways to evacuate smoke now that do not interfere with, as Dr. Sharma says, his ability to complete the surgical procedure. We love surgery. We love surgeons. We love the patients who come into the operating room. Our goal is to provide the safest workplace possible, and getting rid of the smoke that we all breathe every day is one of the ways to do that.
Thank you. For our final comment on this measure, Chairman Cooper.
Well, thank you very much. And first I want to say, Ms. Horn, I'm sorry about your diagnosis. And I really appreciate you coming down and taking the time to share with us. Hopefully, whoever that doctor was that said you ought to be dead by now, hopefully you will live many, many more years and show how wrong he was. And, but it's the kind of testimony when you come and talk to us that makes a great deal of difference. We did get a thing that the bill has, that some form of this bill has come over from the Senate. I don't have any idea because we don't read Senate bills until after crossover day, which means that we will have a chance to look at this issue. It wouldn't be Representative Collins' bill, but, you know, we will certainly, you know, I'm sure that'll be coming to us. And I will, you know, look at it and look at your bill, and we will do an evaluation of them when they come across. And this is not dead, even though it's just a hearing. And I'm sort of shocked because it's always been that the doctors in the Senate were basically just said no to this. And so, as you know, many people in this room know, bills have to pass both chambers before they would ever get to the governor. And so when one group was saying basically no from the very beginning, there was no use in us hearing it and trying to move a bill over. But obviously something has changed their mind about this issue. So we'll be looking. And I think what happened, it got off on a very bad start down here because some nurse who was working for a specific company that made a specific kind of, little handheld thing came down and was very in our face about it and how that was the only great way and the only thing we should be using. And it, seemed like it was very self-serving. So I think that started a few years ago, a real negative look at this. So just to give you a little background so you'll know what happened. We have trouble with people who come down and seem to be trying to sell us or have us pass a bill that is for their specific product. So it helped that you said that there are all different sorts of needs. So thank you to everybody that's come to talk to us about it. And I want to thank my stand-in. You've done a great job, Representative Gaines. Thank you for doing that. I apologize to the group. I was with the speaker trying to work out issues on another bill, which is what we do at this time. So with that, back to you.
Thank you.
Thank you, Mr. Chairman. Thank you, Madam Chair.
You're welcome.
Honored to be your stand-in.
Okay,
This meeting now stands adjourned. Thank you all for being here.
thank you.